In the United States, TAVI over in Europe, TAVR here, is really kind of an interesting operation. It's one that is now expanding with the PARTNER 2 trial into examining it in more intermediate risk patients. And I'm with Professor Alec Vahanian, head of cardiology, Bichat Hospital, Paris, France, and we're talking about the dynamics in patient selection from inoperable to moderate risk, TAVR versus SAVR, and what other new trends in Europe?
Well, the first point is that this technique is there in Europe, started here in 2002, CE mark 2007, so it's here for years. We have guidelines, and in these guidelines issued in 2012 by both the surgeon and the cardiologist, we clearly stress the fact that this technique should be today restricted either to inoperable patient or patient at high risk, and we wrote, it was in 2011, and you published in 2012, you write in 11, it should not be done in patient at intermediate risk.
Right.
We need trials. So this being said, in this document, as should be done everywhere, we put a lot of weight on the concept of heart team. And the concept of heart team is a way to go to define the risk and the expected benefit of the patient. Because we have scores. You love the STS score, we love the Euro score, both are terrible in the field of TAVI, because there are very few patient TAVI or TAVR-like included in the reference sample for building this score. They are not good. We know that. What is good is the judgment of the heart team. Of course, the judgment should include this score somewhere, but also integrate porcelain aorta, integrate bypass mammaries, crossing, etc., cirrhosis, and so on and so on. The patients we are dealing with are so heterogeneous, there is no way to have black and white answer, no magic number. So, to come back to your question at the end of our discussion, yes, there is a move. We are treating more and more patients. Now, there are very good data from the German registry, very good data from the British registry, showing that in the early years, the number of surgery went up. With TAVI, patients came to the hospital, both did derive benefit. We are treating more patients. It's very good because there were many untreated patients. So both went up, but now in both countries, Germany and UK, surgery is going slightly down, and TAVI is still going up. That's a major trend we are facing. Is very good for the patient. Second point, I think we are treating less and less very, very sick patients. That's good, because treating patients with a limited life expectancy, the guideline we said 1 year, it could be 2 years, is not good. They won't end up by a full recovery, and they will die soon from the associated disease. That's a place where we have to work more with geriatrician, nephrologist, pneumologist to eliminate the patient who won't derive benefit in terms of quantity and quality of life.
So you're now looking more 3-year survival after.
It's so difficult to say 1 year. It's even more difficult to see 3 years. But for example, you know, we saw in several presentations years ago, patients will die from COPD after TAVI. Of course, if you bring to TAVI someone who has been 3 times to emergency care and be ventilated several times, it's useless to do TAVI. You know, they will die from COPD. It's the same with oncology. If you are dealing with a patient who is going to die from the cancer the other year, no way to do that. But if the oncologist says, I don't know, it could well be 50% at 5 years, you should go. So it's an individualized decision.
What was also interesting last night was how the bar keeps getting raised, because with surgery, the numbers keep getting better. Yeah. Every year, the numbers go down in terms of mortality. That's impressive.
That's good. You know, our surgical colleagues, sometimes, if you tease them, they'll improve. And the goal is to offer the best treatment to the largest number of patients. So we are successful. Right. I'm very happy with that. Now, the other point is, well, some people used to say, well, in Europe, you treat all the patients intermediate. Well, it could be partially true, but it is not what we are aiming at. Once again, when you say we are treating intermediate risk patient, you are referring to the STS score. But please read a very good paper coming from Bern, where they showed the fantastic result they obtained when treating STS between 3 and 8 and STS below 3. But read the paper and read the fantastic editorial by Patrick Serros speaking about the art of patient selection. In point of fact, among the so-called low-risk STS below 3, the heart team judged that large number of them were inoperable because of anatomic condition and so on and so on. So it's too oversimplistic to refer only to this score. If the heart team decide we should go, even if the STS is below 3, I think that we should go. It's a heart team decision. What is terrible is to have a surgeon deciding straightforward to operate all nonagenarians, and a cardiologist decided to treat by TAVR or TAVR all the 70-year-old person.
Right.
So work together and run the trial. You just finished the partner. We are eagerly waiting for the results. It'll be extremely interesting. We'll have the third TAVR. British colleagues are running a trial. Danish colleagues are running a trial. All this evidence will come and support what will happen, and I'm quite 100% sure that we are going to use this technique in intermediate risk, probably not in low risk, because with low risk will come the age and so on, and we need some follow-up. The follow-up today is really short. 6 years we know where we are, 7 years, but 10 years we don't know. So.
Well, in this particular procedure, we're learning from you, and you can learn from us.
Yeah, exactly. No, we advance all together, and I think the very good data which are explored by partner group are extremely interesting. We should consider everything, the German experience, the French registry also, which is very famous.
That's true.
We are building the evidence, and when you have a registry with a 1% stroke, with no fatality, etc., at the end, well, you say, this registry are probably not that good. But the other one were grossly on the same line and help building the evidence.
Well, this is at CRT 2014 for Dr. Vahanian. Please check out the rest of our coverage in CardioSource World News. I'm Executive Editor Rick McGuire.